name is Kristin Pracitto. I'm the Vice President for Child Services at Wellmore. And I've been at Wellmore for almost 10 years now. I actually went to school for a little while in Waterbury. But I came to Wellmore because it is a community provider that I feel like represents true connection and caring to the community. One of the things that I really loved when I was interviewing there, and I knew people there for many years, was that Gary, who is our CEO, is a Waterbury kid. And so he grew up the street from our original clinic. And so for him, this is everything that we do for Waterbury is personal. And for me, having a home location, a place that feels personal and connected to the community is very important. And so that's why this conversation actually is really important for me as well, because I want that connection to exist in a way that makes sense for you, so that if you need anything, you can call me up. I've had vice principals call me up and just say, I have a scenario. Can I run it by you? Yes. The answer is always yes. Let's work it out together. So how many people have heard of the Urgent Crisis Center? Yes. You made me very happy. How many people get my last emails? I'm redoing the list, so anybody that did not raise your hand, you will be on the list. So my goal and my purpose involved in being involved in the Urgent Crisis Center is to get the word out, because I am so incredibly proud of this level of care. I've been a social worker for 30 some odd years. I don't know how that happened. But even back in the 90s when I started, there was a recognition that kids don't do well in the emergency room because it's a really stressful place. And I'm not trying to malign emergency rooms or the nurses or doctors or staff that work there, because they are excellent at what they do. And it's not the place for a kid who's struggling, right? When my husband had a panic attack a couple years ago and thought he was like stroking out and dying, because he's a little dramatic sometimes, we went to the emergency room and he was there for 37 hours because he kept saying he was having more panic, but he wasn't describing panic, he was describing a heart attack. And even though I said to the doctor in hour 2, could this be a panic attack? You know, sometimes people say they are having a heart attack when they're feeling really panicky. And my husband said, no. And the doctor said, no. And I was like, no, this is what it is. I know this for a fact. But we were there for 37 hours. And I'm grown and he's grown. There was a person handcuffed to a gurney in front of us who was passed out with overdose and came awake while we were there. There was somebody next to us who had been in a car accident and was very, very uncomfortable and scared. There was a kid that went by screaming. All of these things over the course of many hours that we sat there. My frustration level, because nobody was listening to the whole panic attack idea. But the more that I sat there and I listened to the environment, the more sad and concerned and scared I got for kids who might be sitting there waiting for something more intensive or something different because they feel scared or alone or isolated or they feel hopeless and helpless. It's not the place for kids. Emergency rooms are great for what they do. But for kids with a mental health concern, we know they need safety, security, calm, a welcoming voice, open curiosity, no judgment, no rush, work at their pace. You all know this, right? This is the simple stuff. You all know this. The ED doesn't either. And so the UCC provides us an opportunity to do things differently. And I have to say that when I was writing this grant, I was pretty anxious. I thought that we would get all these kids who were trying to hang themselves or kill themselves, and all these kids that were cutting and bleeding, and it was terrible, and they were all so acutely disrupted. We see kids who are suicidal all the time. We see kids who are injuring themselves all the time. But it's not the movie version of that. Kids are kids, right? Kids who are sad or anxious or depressed or feeling hopeless or helpless, they're either probably presenting as sad and shut down, or angry and shut down, or sometimes angry and a little bit louder. So feelings get manifested in really different ways in kids. And so what the UCC provides is a safe space to work through some of those feelings and make it different. So glasses down. So we know that the ED wasn't a place. So kids would be able to access mobile crisis for crisis support. They could go to an outpatient setting. They could access intensive in-home programs like ICAPS or FFT or MST, or you can jump all the way over here to inpatient. We also know that there are only 161 beds in the state of Connecticut. That's it. And so for every kid that goes to the ED, the chance of them going inpatient is actually like minuscule, because there are probably 30 or 40 other kids competing for that one bed that opens up. So again, that's why kids get stuck in an emergency room, and that's why kids don't necessarily do well in that transitional period. We know some kids do need emergency room care and do need an inpatient level of care, but most of them don't. So we have that big gap. We also have kids getting stuck for hours and days and days. We also have the lack of inpatient beds. So in Connecticut, there are 161 beds. Of those beds, only about 75 of them are available to the entire child spectrum. We have several units in the state that are teen specific, or young child specific, or eating disorder specific, or like middle age. The broad range is very, very small, and so that limits the availability of inpatient beds. What we do know is that EDs can add trauma, add anxiety, disruption and disconnection, and do not help stabilize things. We also know that what happens in EDs is that you're operating at an ED pace, which is like a little like a sprint until it's not, and then a sprint until it's not. And so you spend a very short amount of time talking very quickly to a nurse or a doctor or social worker trying to tell your story, and then you sit and wait for the next person to come. And that very small amount of time, the child and the parent are sitting and trying to communicate themselves to that person about what the worry really is. And what happens is they often go like this. Mom says, I'm really scared because he's doing this and he's destroyed his room and he's done this, and the kid goes, no mom, that's not it. I'm not angry, I'm this. And they have this argument in front of the staff. Nobody actually hears the middle ground. And then the staff member says, thank you very much, and walks away to go process that and figure out what the next step is. And the parent and the child are still left there clashing. It's also not a place where we can do much clinical care because of that. And that also is where the UCC becomes incredibly, incredibly important. Part of what my background is, so having done this, having worked with kids and families for 30 years, a little bit about me, I have spent the majority of that time doing home-based work. And so I started working with kids with HIV and their families in Stanford. I did the same thing in New Haven for many years, providing therapy to kids who were infected, to families who were infected, in their homes, in their communities. For me, that was a transformative experience because it allowed me to see how people were living and respect their choices a little bit differently, and to understand that my therapy with them, my work with them, in their rooms, in their living rooms, in their kitchen, it was kind of, my great aunt's perspective, my words were in their space, so the next time the kid escalated, I felt like it was easier for the family to say, oh wait, we sat here at the kitchen table, and Kristin taught us those 4 steps we have to do. I'm gonna try to do those 4 steps. The first step, what did she say? Oh, remember she was doing that thing like this. That's right, stimulation helps. So can I get them to stimulate in a different way? Instead of punching the walls, can we say, let's go for a walk? And it becomes alive, and it becomes powerful. But what it also created for me was an understanding of how important shared vision of care was, because the vision had to include families' home and where they were living. And then, so after doing the HIV work, I did many years with the ICAPS network. Some of you, I see faces that are nodding, and I'm wondering, ooh, did I train you? So I was the trainer for many years. I was program lead there at Eagle Child Study Center. I eventually was the point person for the statewide network, doing training, consultation, evaluation. It was an incredibly rich experience. But again, throughout all of that, what I learned was a shared vision of care made all the difference. And so in ICAPS, we would call that co-construction. That's what I tried to build into the UCC, the idea that we are collaborative and inclusive, and we were deliberate in the choices and the things that we're saying, and that we take innovative approaches and be creative in the face of struggles, and that we're committed to doing it until we find a solution. And underpinning all of that is the idea that the family has to be part of it. Can't solve the kids' problems in a vacuum. And I bet this is probably some of your struggle, right? Because you're in school and you have limited contact with the families. And it's not possible to say, hey, your kid is struggling, can you come in after school and we'll work this out? Because they go home and they have their own lives at school. But for us, having the family and the youth together, working together towards a solution makes all the difference in the world. You can feel, so if I go off or you have questions, please feel free to so there are technically four UCCs in the state. Wellmore has one, the Village for Family and Children in Hartford has one, Child and Family Agency in New London has one. Yale is a different thing. So those 3, Village, CFA, and Home, are all community-based. So we're in the communities, connected to communities. Yale's UCC, which is being built right now, is in their emergency room. So part of the purpose for me to go to a UCC is to avoid an emergency room and avoid that contact. If you go to Yale, you do still have to go through an emergency room. Some people will choose that because Yale actually has a tremendous amount of resources and they think, oh, I can get someplace sooner. But the goal of the UCC is not to get someplace sooner. The goal of the UCC is to create a new shared vision and a safety plan and connection to care that makes sense and get the kid back to the home. And so Yale is doing their work, and that's great. So our UCC, in case you haven't read my emails, is at 141 East Bay Street. We are diagonal from the Palace. We are next to UConn Waterbury. We were 24/7. We are in the middle of some funding discussions, so we have had to adjust our hours. We looked at our data since we opened and since we went to 24 hours a day, and our data showed us that most people come into the UCC between 8 in the morning and midnight. And so we shifted our hours. We eliminated a shift, we eliminated night hours, but we made the hours that were open the ones that families said choosing to come down. We've had a lot of kids walk in at 10 o'clock. We had a family, unfortunately, come in at 1:30. Their kiddo had skipped curfew. And so they went in and sat on the kiddo's bed until the kid tried to find a room. And then there was a fight. And then they showed up at like 1:30 in the morning. We safety planned with them, and we talked with them, and we were able to create a different plan and send that kid. So the goal of the UCC is to be responsive to kids with high needs and kids who are struggling in any way that a family defines the crisis. And so one of the things that I hear a lot is that families and providers. The reason that you can send a kid to the UCC is if they're suicidal, self-injuring, or homicidal. That's not it. It's about the family defining the crisis. And so we can see all of those kids, absolutely. We can also see a kid who's dyed their hair. Now, in my world, the weirdest thing that a teenager could do was go kind of goth and dye their hair black. That was a big deal 30 years ago. Now everybody has their hair, who cares? But a kid that goes from captain of the soccer team, president of this, president of that, and transitions and then starts withdrawing and stays in his room all the time. A kid who becomes extraordinarily angry or extraordinarily shut down. Any of those kids could be an appropriate referral to the UCC. Because what we're going to do is say, how can we help you? That's the key. How can we help you? You define the crisis. You tell us how we can be most helpful to you. The kid is saying, I don't feel like I can live. I want to walk into traffic. Okay, tell us more. The kid is saying, I don't know why I'm here. I filled out all these screeners at the pediatricians, and they said I ranked high. What does that mean? Well, sometimes in pediatrician, and then we'll explain that, and they'll say, oh yeah, I've been feeling really nervous because I'm going from 8th grade to high school. I'm no longer the big fish, and I don't know what to do about that. I don't know how to be friends with all of those people, and I feel really scared. Okay, let's work on it. So the range of problems that we can see is really big. I think the other piece to this is it's an immediate access point for a mental health evaluation. And so for a family that has moved here new to the community who doesn't know what the resources are, for a family who may be having a profound change in their lives, profound trauma, something like that, it's a resource for them. When we see kids at the UCC, there are clear things that happen. So we can serve kids between 0 to 18. Clearly the 0, 1, 2-year-olds, even 3-year-olds, they have a different type of presentation and a different type of need, right? Doesn't mean that they're not exhibiting behaviors that are more challenging, but it's more about parenting and parenting support. And for those kids, our intervention is going to look a little bit differently, and we're going to connect those families to the right parenting supports, like Child First, like parents as teachers, like an early intervention preschool, things like that to support them. For all the other kids, we welcome them in. We do a triage process, which means that we're trying to determine why they're there, what's their need, how we can be helpful. For kids that are presenting with really big behaviors, so that means kids who have attempted suicide in the last short period of time, a day or two, those kids probably do need to be evaluated in the ED. However, because we know clinical care doesn't really happen in an ED, it can also be helpful to have that kid come to us. We do an evaluation, we determine safety, we create a safety plan and connection to care, and then make a determination, is the ED still needed? Or do we feel like all of those decisions we've made have made sense and can put this kid safely back in the community? And for each kid, it's going to be different. If kids are actively bleeding, they need a medical intervention. They need stitches, they need lifting. If they have done self-injury that has done profound damage, we had a kiddo who did some pretty deep cutting, that kid needs a medical intervention. They punched the wall. Yes. If they're so out of touch with reality that they can't engage in a conversation around safety, yes. But we will always work together with the child and the family to try to avoid it, and then make a determination about what to do next. We will, if the kiddo or the families, because sometimes the parents are escalated, come in, we will calm things down. Part of that is giving the child and giving the parent time to talk with us independently of each other. So instead of going like this, they have a safe space where they can talk and talk about what they're feeling, how they're feeling, when it started, whether it's bad or worse. and get that out. And what that does, it moves them from this really crisis-driven, intense place to a place where they can say, I need to think about how to do this. It's a problem-solving approach. It's a solution-focused approach that happens after we've had that independent time with the parent and the board guardian and the child. We provide a thorough assessment to these kiddos. So we're doing a full diagnostic evaluation. We are having them meet with a nurse to do a nursing assessment. We are having them meet with a family support provider to do a bunch of measures so that we're kind of balancing what we're hearing from the family with some discrete evidence-based measures. And we're providing that de-escalation, that calm, accepting approach. And we are moving the family towards that solution. We then do a huddle with our psychiatrist or senior social worker who's out at the scene. We have APRNs, we have social workers, we have psychiatry to help support this program. And from that, we then make decisions about what type of care and where and what else we think needs to be in place to help this kid. And so that means a couple of different things. It means we walk back into safety plan with the parent and the kiddo and the parent with ideas already in hand. But then we say to the family, this is what we're thinking. Does this make sense to you? Do you have a sense in your community whether you want to go to Wellmore or to CMHA or to Wheeler or to FCA or to a private practice? And if they say, oh, I want this, okay, we'll give you that information. We'll help that connection happen. We are not dictating where they go. We're identifying levels of care and then helping them to make choices around where they get that care. And I think that's really important because we don't have a catchment area. So kids can come to us from any place. So this afternoon I'm going to Fairfield to do this whole spiel again. Fairfield is not in Wellmore's catchment area, but Fairfield recognizes the kid in the ED is not a great thing. And so if we get a kid from Fairfield, and we have, we are doing research and identifying services in that area, and then saying to the family, which of these sound good to you? So it's really about family-driven choice and family-driven. We connect the families to care, do that care coordination piece. We're looking at natural supports, informal supports, and professional supports. And then once the child's been discharged with a safety plan, we then follow up. And so our care coordinator will follow up. If it's a high-risk kid, the clinician will follow up. So we're providing that kind of bridge to whatever is next. As I said before, we have APRNs, we have MDs, we have senior clinicians, so I'm on call. Oh, 9:30. I'm on call for another half hour, so if my phone rings, I thought I was done. We have clinicians who are social workers, counselors, or family therapists. We have family support professionals who are bachelor's level folks. We have care coordinators who are really experts in resources, and then an admin team. At any given time, when a family comes in, they're going to be seen by all of those people. And the intervention moves at the pace that the family can tolerate. And so for many families, that may be long discussions where they're doing processing before we ever get to problem solving. Or it may be quicker. I gotta pick my kids up at 3. I'm here at noon. Can we be done by 2:30 so I can get across town to get my kids? Of course, we'll work as quickly as we can. So again, our space is 141 East Main. We have parking that's lit and secured. We're open 7 days a week from 8 in the morning till midnight. On Saturdays and Sundays, our data showed that being open from 10 in the morning until 6 at night was the best utilization of our time. Early morning, nobody came in. After 6, everybody had a sense of what else to do. So, Monday through Friday, 8 to midnight, Saturday and Sunday, 10 to 6. We need the parent or the legal guardian to be there. And this is really, really important because they're part of this. Kids don't live in a vacuum. In order to stabilize and problem solve and create a new plan, the parents have to be involved in that. Here's the cut, and they also have to, of course, sign the consent. The caveat to that, or the exception to that, is sometimes families have jobs that are very far away. And having a kid sit in our room isn't actually any better than having a kid sit in the room, because they're bored and it's not solution focused. We also can have, if the family has a trusted adult, so if the kids go to grandma's after until mom gets home at 7. Or if auntie across the street is the one that takes care of the kids before school. If there's somebody that's trusted, that's connected, that is supportive of this kid, and the parent gives permission. So we'll call the parent, we'll ask for verbal consent, and we'll ask that parent, is it okay that Aunt Joan is involved in this care? And we'll call you when we're talking to her, and we'll get your input. We can do this over the phone. Is that acceptable to you? And if families say yes and they give us verbal consent, we can do that. For foster kids, we call DCF, foster parent there. And we need somebody there who is a resource. So kids can't come in technically by themselves. We had an 18-year-old that came in that actually I had met in the community, so I knew her and I knew that she was struggling. She came in, her mom refused to come in. We were able to talk to mom, and she was able to call her best friend's mother, where she had been staying with mom through. And the best friend's mom came over. And mom said, do whatever you need to do. Yeah, you can involve Mandy. And Mandy came over, and it worked. We bill insurance. But insurance is not a barrier for care. So if you have a family who's undocumented, absolutely send them over. If you have a family who has like one of those high deductible plans or has co-pays, we will make it work. If a kid shows up and is in crisis, our job is to make sure that kid gets care. We can't turn kids away. Average length of time from triage to discharge tends to be about 3.5 hours. So it is a time investment. But that time is, for the most part, spent in conversation with people. So the whole process, or most of the process, feels like you're doing something towards a solution. And I think that in and of itself is a step in the right direction. Here's some pictures of our space. Part of this, probably actually the most stressful part of this for me, was picking out colors and furniture. I am not an interior design person. My mother was very helpful to tell me what colors to avoid. My favorite color is orange. She thought that was probably a bad choice. Very helpful. So everything is in kind of mellow, calm colors. All of the furniture is super high intensity healthcare quality furniture, so you can't pick it up. We've had situations in our outpatient clinic, in some of our other programs, where kids have tossed chairs or flipped desks. I'm sure you've seen that as well. There is no way that's happening to this furniture. There's also no way we're ever rearranging these rooms, because each piece of the furniture has bags of 44 pounds of sand in the bottom. So there's no way it's moved. That rocking chair in the upper left-hand picture is called a Zen rocker. It is my favorite piece of furniture. I can give you the contact information for where to buy one, because it's more comfortable than any lazy boy or remember finding a chair out there. We've also had a kiddo who managed to, the only out of control kiddo that we had in the UCC who was a struggle was 5. Probably somebody in this room knows him. And he went from the couch to the chair to the window to the couch to the chair to the window to the couch, and he was bouncing on it. He surfed and balanced on the top of that rocker. And the rocker did not tip over, and he didn't fall and break his head as I stood there like, and he was able to touch the ceiling, which he thought was very good. And then he jumped to the beanbag. So the beanbag, every person in the world walks in and says, oh my God, it's a beanbag, and goes diving for it. We had firefighters that came now 2 years ago to tour the center as we were talking to them about ambulance transport. One of the firefighters was like, oh, I love beanbag chairs. Went over, sat down, we spent 45 minutes talking about the UCC. And then he tried to get up, and he's like, oh, I'm not 10 anymore. I need some help. I have bad knees. But the kids love it. We had kids take naps in it. The couches actually are comfortable, but it's all mellow, right? And it's all kid-based. So you see crayons, you see toys, you see posters that are like therapy posters and kid-friendly posters. But we also have things like Winged Dinosaurs, which is that orange thing at the bottom, which we've been told we are very cool because they are very hot right now. So whatever that means. We have tablets and kids. Here's what we do, and here's what we know. This says 94, it's actually 95% of kids that have been served in the UCC have gone home with a connection to care safety plan and a sense of confidence as they go home. That's remarkable. Where else in the world do you do something and get 95% success? It's an increase in immediate access to mental health care and an evaluation of connection to care. We know the system really well because we're the UCC and it's an alternative to ED. Sometimes we can put some pressure on some other agencies saying this kid was evaluated, they are very high risk, and get them in quicker. Sometimes not, but sometimes we try. 97% of guardians say that it's helpful and they report satisfaction and they would recommend it to other people or they would come back. And we've had repeat people. And they are always, we had a kiddo Thursday last week, she had been seen a year before and she walked in and she's like, I need to be back here, but is Tori here? Because I saw Tori last year. She was really helpful and Tori was there, which is awesome. Tori is talking to the group in the afternoons. There's another group like you that's meeting in the afternoons, she's talking actively. We know that this decreases trauma. It decreases trauma in the kids. It decreases trauma in the parents. And it provides a reparative relationship and opportunity that is different than what you would get in other levels of care. Because we are problem solving from within. We are calling and acknowledging and validating from the get-go. And we're saying, what can we do differently? And how can we build the relationship differently? Part of this is about helping families to remember that they used to get along really well. And they used to enjoy each other. And so going back and talking to them about what was the last fun thing that they did, or what was a routine or a ritual that they used to do regularly that made them feel like they were buddies or friends. One of the early kids that we got, they walked in, mom and kid were screaming bloody murder at them. I happened to be in a meeting in our first floor area where we do triage. I was with like all these VPs and the head of the agency, and these people come in screaming bloody murder. Our nurse comes out, sounds like you're really upset, can you come in, let's talk. And she did some triage and she calmed them down, we did our intervention. During the course of the intervention, there was a discussion about what the strengths were and what they liked to do. And the kid said, well, we don't do anything anymore because mom's too old. So, okay, those are fighting words, but we're not going to go there. And so we said, maybe curiosity, because curiosity is what is important. What do you mean she's too old? She used to do Dance Dance Revolution with me, now she can't because she's too old. My mom's like, I'm not too old. And so then they put on music and showed the clinician a routine that they did when this kid was like 11 to Dance Dance Revolution in the office. And so the two of them are bopping around and jumping. I can't dance. I can't even pretend to dance. But they were bopping around and laughing and having fun and remembering together. Now, the nurse practitioner who was on the second floor underneath all of this thought we were having a brawl, but everybody on the unit could hear the music and could hear the laughter. And that was the transition for this family. They were able to understand that they had gone from being connected and related in a way that was really not just mother and daughter, but family, to I am the mother and I am going to tell you what to do. The kid saying, I don't want to do, typical adolescent stuff. they were able to connect back to an earlier time. It made a huge difference. And they walked out hand in hand, laughing, doing dance steps. And we had cameras, so we were able to watch them walk them out. It was very cool. There is amazing stuff that happens in the UCC around here. So there's data. I won't tell you all this data. I'm going to lose all of you in about 2 seconds. Somebody's going to start snoring. But there's really amazing positive data around utilization, around outcomes, and around equity among the outcomes. So there is not a distinct difference depending on somebody's ethnic background. Probably most important to us are the comments that we get from families after the UCC. So we have everybody fill out an evaluation, and they give us comments that tell us what we've done well or tell us that we don't do things well. So the fact that we didn't have, what is the super bloody one that's out? Warcraft, World of Warcraft?
Call of Duty.
Call of Duty. We didn't have Call of Duty 17.2, and that made us really bad and boring. We're not going to have a shoot on the game on the UCC where we're supposed to be calming you down, but we were bad because of that. But parents say, I was happy, or kids say, I was happy I had somebody to talk to. Thank you for making him feel comfortable and not judging him for his behaviors. Staff made my child feel safe and secure. I felt heard and my concerns were addressed. I felt like people who took care of me today really cared about that. One of the kids that I supervised a case early on was like, you didn't tell me what to do and what you expected. You asked me if we could choose something different. And think about that. So many parents, and all of us as adults, we tell them what's expected. And so he felt engaged and involved in the discussion, and it made a difference for him. We also get told we have to pull snacks. So that's good. I brought a kid upstairs the other day who had been growling at me and was very upset at me because we were going to the UCC. And when I said, hey, we've got some snacks, what do you want? He was like, I'll take one of everything. And I brought it and I said, you can have 3. He's like, I'll take 5. And I had 8, and I was like, oh, okay, you can take 5. Because he was at least engaged. So take homes for you all. We're available 7 days a week. No appointments, no referrals necessary. We're at 141. We're open those hours. We have a main phone line, so that 203-580-4298 is our phone. We answer it all the time. If you have a kiddo you are interested in sending over to us, or that you've told a family about us and suggested that they take your kiddo over, give us a call and give us like a little thumbnail of what's going on and what you're worried about. Oftentimes when families show up, they tell us a very different story. Sometimes they say, I don't know why I'm here. Other times they talk about things that are not your concerns. It's nice for us to have a little insight into what you're worried about to add to the picture and try to talk about it with the family. You don't have to, but it's a really good way of giving us that heads up. It also gives us a person to call back. And so we try to get releases from people all the time so that we can provide feedback, give you a copy of the type of crisis plan if the family desires that. But sometimes we don't. The other day we got a kid from Access Mental Health. So the pediatrician called Access Mental Health. Access Mental Health called me. Kiddo came in, but then the parents refused to sign any releases. And so the Access Mental Health person called last night and said, so did you see so-and-so? I was like, so I cannot confirm or deny that this person was there. Because I can't. I can't say whether they were or they weren't. Which puts us, so we try to get releases. So questions and problem solving. I'm really curious to hear from you if you've had experiences with the UCC, if you've had feedback, but also, do you have ideas about how we can do this differently so that we can be more of a resource to you? Because what we know in Waterbury is we have lots there are lots of kids that are struggling in lots of different ways. And you guys are working really hard to support them. Are there ways we can be helpful to you that makes that a little bit easier and gives the kids a better outcome? We've had,
I was gonna say, our building has a family liaison, so I don't know if you guys ever reached out to them as well.
it's on my list. We had a time that I was supposed to meet with them a couple of, I think it was during high season. So our high season tends to be, not be surprised by it. September, October, November, early December is really busy. Things settle out for the holiday season. Mid-February to the end of school, things are really busy. So I think I was supposed to see them during one of the high seasons, and I got called in and I had to do intakes or I had to do UCC stuff, so I didn't get there, but I will reach out there. That's, how else can I be helpful?
I just have a question. So
Yes.
I think this is great. I know specific in one of my seniors last year utilized this with their mom and one of
Good.
it did help. So in a case where we're in school, we're on a school day, and a student is presenting suicidal thoughts, typically in class, so we contact 111, or show them out to school. Do you still feel, or do you feel that that is the protocol we should do, or should we, if the parent's willing to pick them up in that moment and bring them here, would that be better than send her away?
So it depends. No black and white. My husband is a chemist. Everything is black and white. Everything in my life is gray, and it depends. So Wellmore holds the contract for mobile crisis. So it's Wellmore staff that are coming out. We work in partnership with them all the time. It depends on how the child is presenting at that point. If you're really concerned and you want an evaluation sooner rather than later, you could choose to call mobile crisis and have somebody come out, or you could choose to have the parent come in and bring them to the UCC. It may depend truly on how they're presenting and how worried you are. It may also depend on what the relationship is with the parent and whether they're comfortable and have past experience with mobile crisis and are fine with it, or whether they would be worried about that and prefer to take their child someplace else. People are very, it's a very similar process. The UCC just takes longer and has more people involved. So the evaluation and decision making is very, very similar. I think we at the UCC have a higher threshold for risk just because we're in a contained setting as opposed to a family's home or the school. But it really depends. We have had situations, so just last week we had a kiddo who was in a Waterbury school and presented with some really escalated behaviors, but it was also sick. I'm not going home, it's not safe for me. Mobile crisis went out, did an evaluation, tried to calm things down, tried to get the kid to a place where he wasn't so adamant he was never going home again. Things continue to kind of escalate at work. They didn't settle. And Dad came in and picked up the kid and brought him to the UCC, and we thought maybe we just need a little bit of time and space to work on this. And so that was helpful because even though mobile crisis had done their bit, the ED wasn't where this kid belonged. It was kind of a placement thing, and so we could use the space that way. It's a little more complicated than not open 24/7, but we'll make it work.
Just to piggyback, because I had a student that kept hospital for like multiple times last year, and when they came out, when they decided that they needed further impact, they bring them there, so they don't really do it. And I believe that the ambulance will bring them there.
Yes, so that's the one thing I haven't done. So it can be, there can be times that we'll say, yes, this kid needs to go. It's really dramatic, we will send them to ED. But our goal is to not do that. And so we have had, in the past year, we've had 12 kids that have been seen by mobile crisis, and then mobile crisis has determined they need more evaluation, more time, more stabilization, more involvement with mom or dad or caregiver to get to a place of stability, and then they bring them to, they have the parent bring them to the UCC, or we call it the UCC, and that's fine. And so you guys are in the bonus situation of being Waterbury. So ambulances can come directly to the UCC. That is easy, commercial, it's a little more complicated. but it is written into ambulance statute. So that's a fantastic thing. I feel badly that a kid has to get to an ambulance, but if that's a way to get them someplace other than the ED, that's great. We also have had ambulance teams who have done this now a number of times, who are fabulous with kids, getting them into the ambulance and then walking away. They're not tied down, they have to be restrained because they're ankle, but they're not tied down in a stretcher. It's not some one flew over the cuckoo's nest kind of environment. They get to know the kid, and they support the kid to get them in and they stay and make sure that transition goes smoothly. So, yes, thank you for saying that. Yeah.
Is the ambulance ride something that like families will then later be billed for, or like
Say that again?
like is the ambulance ride something that the parents would end up billing for?
They might end up billing for.
Yes.
That's why it gets a little complicated. So under Medicaid, no. Under commercial insurance, maybe. Depends on the commercial plan. So we have had one child transported from a school, not Waterbury, outside our immediate area, had commercial insurance and the ambulance ended up. And the family, and of course the ambulance bill comes like 3 months later and it's like, what is this? So we have had a bunch of discussions now with bigwigs in Hartford saying this is not the way it was meant to work. They're not supposed to get a bill. This is an emergency service. And so we get into a kind of rigmarole around what emergency is and what it's not. But we have referred that family to the healthcare advocate, and so they are also pursuing that with the commercial insurance. So with commercial, it's a little more complicated, but for a member in families, it's easy. But good question. Thank you so much. What other questions? How can we be more helpful?
If we have community events, like socials within our school, would you have spokespeople?
Yes.
willing to come out and speak
Absolutely.
for parents?
Absolutely. Anytime you want. So we do a ton of outreach events. The Global Crisis or the UCC staff will go. The back to school rally, they were there. Last week I spoke to the parents at open house at Crosby for the freshmen. So they had me get up on stage and spotlights, which we don't do well with spotlights. But talk to them about UCC and crisis support and thinking about transitions to high school and managing the emotions. Happy to do that sort of. I can do that sort of talk to this group. I can sit down and have lunch with people. I can have people do that. Always. I think the one thing that's an important point for me. The one thing that I've been trying to do this summer has been increase my awareness and ability to get information about the UCCs directly to parents, directly to families. The effort really has been talk to as many providers as you can, because for every one of you, you have 50 kids, 100 kids, whatever, and you'll remember to talk about it. Which makes sense, except you've got 50 or 100 kids and you have some windows remembering. If we can talk to parents directly, we want to do that. So the family liaisons, absolutely important. Any type of support groups or parent meetings, absolutely. And I Yep.
Do you have counseling services for parents who don't speak English, but they're interested, like, you know, like a recommendation call, but they're like, well, what about the language barrier?
So you're asking about speaking other languages and our access to other services?
No, so
ongoing
let's
services?
say a child is presenting, you know, as they should be seen further, and we contact the parent, let's say in Spanish. What if they ask, you know, do they have somebody to speak Spanish or translating services for them to communicate with the parent?
So Wellmore has an outpatient clinic and a whole range of other types of programs, many of which have bilingual staff. So we have perfect capacity to manage that. We have a couple of programs that have Portuguese staff. We have one program, one of our clinicians for the UCC is Haitian, so she speaks Creole, which is fabulous. But we also have an interpretation system, so no matter what family walks in, whether it's somebody who's needs ASL or lung or any other language ever created, reused. We have access to people to help us do that. And I will say, we used to have one system, and I lost confidence in that system over time because it seemed like many of the people said they were fluent but really weren't. This system that we have to support us now is fabulous. And so the connection is really good, and the people have been caring and persistent and curious, and it's really been quite perfect. We never want people to feel like they don't have a place to go because they don't. So I would like to touch base with Vera and send out this PowerPoint so you have it. I have half of an email blast written, so you'll be getting another one of those. Thank you all for getting those. They always have our flyer or brochure, a one-pager that says, when do I use mobile crisis and when do I use the UCC, which gets back to that. It depends kind of answer. It truly depends. There isn't a wrong door. It's about crisis support that makes sense for that kid in that moment. And we are in mobile crisis or the UCC thrilled to have the opportunity to support you.